Today we will learn about the vertical problems. A vertical problem can be due to the excessive eruption of maxillary incisor or due to the excessive eruption of a mandibular incisor, which it is easy to identify in the mandibular arch in the form of excessive curve of spee. Our main focus in this video is to resolve the vertical problem in the mandibular arch, which is basically arch leveling in the mandibular arch. This is a phase of treatment. Usually when there is a vertical problem, we treat this in the start, actually the first phase of treatment. So in this video, we will discuss the theoretical background and the clinical arch bending of the intrusion arch, which we will use in the mandibular arch for arch leveling. As I have discussed, the vertical problem can be due to maxillary arch, and it can also be due to mandibular arch. Whichever the arch is at fault, that should be corrected for resolving the vertical problem. We should first identify in a patient that which arch is at fault. For example, our maxillary arch is at fault, then we will do leveling in the maxillary arch. If our mandibular arch is at fault, then we will do the arch leveling in the mandibular arch. In the mandibular arch, to identify a vertical problem, the best indicator is their curve of spee. This video is for mandibular arch. For leveling in the maxillary arch, we will make a separate video. Leveling in the mandibular arch, first we identify the problem in the mandibular arch, which is the curve of spee. Then we categorize the patient into two categories. Either our patient will be of the growing age or it will be an adult. There are different mechanics for growing an adult patient. This video is for adult patient. We will make a separate video on the topic of correction of curve of spee in the growing patients. This video is for the correction of curve of spee in the adult patients. As we have discussed, the vertical problem will manifest itself in the form of increased overbite or deep bite. It can be due to mandibular arch, excessive eruption, or maxillary arch, excessive eruption, or excessive factor is. But the clinical manifestation is increased curve of the clinical manifestation is increased overbite. How we will identify that the problem is in the mandibular arch or maxillary arch. For mandibular arch, it is very simple. If the curve of spee is increased, 98% the problem is in the mandibular arch. For maxillary arch, there are various clinical indicators which we will discuss in another video. So we categorized our vertical problem, which is due to maxillary arch or mandibular arch. We leave the maxillary arch, focus on the mandibular arch. The mandibular arch leveling is manifested in the form of increased curve of spee. Then we categorize the patient as growing and adult. There are different mechanics for curve of spee correction in the growing patient and in the adult patients. This video is for the adult patient. We will form another video for the growing patient. In the adult patient, with curve of spee in the mandibular arch is the basic topic of our discussion today. Now we will categorize our patient into different categories. Whenever the patient comes to you, you will study the patient, match the patient with one of these categories, and apply the mechanics that we will discuss today to that patient. As I have already said, the vertical problem should be treated in the first phase of treatment, which is basically alignment and leveling. This is the leveling we are talking about in the alignment and leveling phase. Our category 1 is very simple. Patient presents with normal inclination. There is no or minor crowding, and there is increased curve of spee. How we will start this patient and how we will do the patient? First, as I have already told you, this is the first phase of treatment. No inclination and curve of spee is present. As we closely look in this patient, we will cement our bands. There should be a double tube band, as the main slot will be used to pass the wire in in the segment of canine first premolar and second premolar, and there will be intrusion arch will be passed in the second slot. So we cement a double slot band. Ideally, there should be a lingual arch bonded to it, but in this patient, there's no lingual arch. But I recommend that whenever you plan intrusion of lower arch, you should place double slot bands with lingual arch. We will do separate leveling. Anterior segment, interior 4 incisors will be bonded, and we will pass the archwire over 2 nidi, over 4, 6, 8. Then we will go to rectangular wire 1725 nidi, 1725 SS in a stepwise fashion. But our segments will, but our arch will have 3 segments. One segment will be incisor 4, and the other segment will be right and left sided canine, first premolar, second premolar, and the molar, and the first molar. The wire should pass in right and left segments. It will bypass the incisors. As you can see in this picture, it is bypassing the incisors. Incisor has a separate wire which is passed in only 4 incisors. Our 4 incisors are aligned in separate segment with wires starting from O1 to nidi to 1725 SS in a stepwise fashion. They will be aligned but not leveled at this step. Our right and left segments of canine, first premolar, second premolar, and molar will be aligned using stepwise O1 2, O1 4, O1 6, O1 8 nidi wires, then towards the rectangular wires 1725 nidi, 1725 SS, and 1925 SS wire. They will be aligned in the arch form by passing the incisors. As you can see, there is archwire sleeve is on the wire in the incisor segment, so that it does not impinge on the inner side of the lip of the patient. This is how we prepare our patient for intrusion arch. Incisor aligned in the segment, separate segment, right and left posterior segment, bypassing the incisor with one continuous arch, bypassing the incisors, having archwire sleeve so that it does not disturb the patient. When we reach the rectangular wire 1725 or 1925, our patient is ready for intrusion. In this picture, there's no bracket on the first premolar, but this is just to give you an idea. In our category 1 patient, when we prepare them for intrusion, there should be bracket on 3, 4, 5, and 6 number teeth and bypassing the incisor. Some people recommend that we should start with continuous arch. We do not recommend that you start a patient with continuous arch in a patient having vertical problem. That would lead to unfavorable extrusion of posterior teeth and propionation of anterior teeth, which is highly unfavorable in adult patient. Remember, this video is for leveling in mandibular arch in adult patients. In adult patients, we do not recommend you to start the case with continuous arch. Start the mandibular arch with separate segments. You are making a separate segment of incisors, aligning them, not leveling, aligning them to the heavy wire, right and left segment, aligning them with one single continuous arch, bypassing the incisors, having archwire sleeve so that it is comfortable for the patient, and double tube band bonded with lingual arch. This patient is now ready for the intrusion arch to be placed on this. We will have a practical demo of how the intrusion arch is made and how it is activated. So we have learned our gains category. First, patients, normal inclination, no crowding, only the problem of curvosity, which is manifesting in increased overbite. We have learned how to prepare our patient. We have prepared in separate segments, aligning them and taking them to a heavier wire so that we can apply intrusion arch on our arch. Then then this is there's our second category. There's normal inclination, but there's mild to moderate crowding in the incisor segment and increased curve speed. For this category patients, everything is same as the case category 1, but as there is mild to moderate crowding, our treatment plan, we are assuming our treatment plan is non-extraction. For non-extraction plan, we need to do the IPR. Whatever the plan is, do IPR in the lateral incisor segment or in the premolar segment, but we will do the same alignment in segments, gradually moving from O1 to heavier wires and doing our IPR in this phase. We will try to convert our case 2 to case 1 category in such a manner that mild to moderate crowding is resolved through IPR. When should this IPR be done? We recommend that you do it in a gradual fashion. You start with O1 wire, do a little IPR. You move to higher wire, O1 6 night eye, O1 8 wire, do a second round of IPR. We recommend you to do IPR in progressive fashion in multiple rounds, not in a single bulk remover. Do it in multiple rounds with giving time for tooth pulp to adapt to the IPR stress. By doing IPR, we have aligned our anterior 4 segment incisors. Our right and left posterior segments are also aligned on heavy wire, having bypassing the incisors with having archwire sleeve so that it doesn't irritate the patient. So our category 2 patients having mild to moderate crowding, we started the case focus on relieving the mild moderate crowding and aligning the arch. With gradual IPR, our case is converted to case 1 category, in which there is normal inclination and there is no crowding and there is aligned segments with separate incisal segment and separate right and left segment. All other features are same. We use a band with double tube, having a lingual arch. We place lingual arch because some of the adverse effect of the intrusion of incisor, there's a extrusive force on the posterior. In adult patients, as we do not want extrusion of posterior, so placing lingual arch will reinforce our anchorage. Our third category is very interesting. This category include normal inclination, but there's severe crowding. Our aim is to convert this category into category 1 patients, maintaining normal inclination and relieving crowding. Our treatment, we are assuming that our treatment plan is extraction of first premolar. We will extract first premolars, segmentally retract the canines using T-lobe canine retractor or any other canine retractor. We retract the canines. After we retract the canines, our incisors are relieved from crowding. We bond the bracket on incisors, pass the wires starting from O1 gradually towards higher wires but we are aligning again. We are aligning in segments. Our incisor is are in separate segment, and right and left sides are in separate segments. After the canine are retracted, we pass a continuous arch by passing the incisors and connecting the right and left side. The left side connecting the right and left side of the arch. The severe crowding was resolved through extraction, uh, but we haven't jumped to the continuous arch directly after extraction. After extraction, we retract the canine segmentally. Canine retractors are used. You can use steel loop or reverse closing loop or any other opus loop or any loop which you are comfortable with. You have placed double slot bands on both sides, connected it with lingual arch, and placed canine retractors. That is how you start the case with doing extraction of first premolars. You start retraction of canines into the extraction space. It will take some time, 3 to 6 months for canine retraction. After the canine are retracted, now your case is converted towards the first category. That means that crowding has been resolved. Now you place brackets on the incisors, align it into the separate segment, and align right and left side of the posterior arch in separate segment as I have shown. So our case category 3 is converted into case category 1, having separate segment aligned with heavy wire placed in it, posterior having lingual arch placed, and a double tube molar band is placed. Now our arch is ready for intrusion. So the intrusion arch will be placed. Now we move to the categories in which there is increased inclination of incisors. We have discussed the crowding categories. Whenever patient comes to you, you should match your patient with one of the categories I have discussed and follow that mechanics. Now we have fourth category in which there's no curve of spee. In these patients, you should have very careful. In these patients, you should have very careful clinical examination, because the vertical problem is hiding itself in increased inclination. When we retract the incisor into normal inclination, the vertical problem will manifest itself in the form of increased overbite. We call this category as having hidden curve of spee. There is a curve of spee in this category patients, but it is hidden with increased inclination. There is no as such curve of spee at the start of the case, but it will appear once we retract the incisor. So we should be very careful in these kinds of patients. We will start this category. We will start with extraction of first premolars. The mechanics will be used in the continuous mechanics will be used in this category. You will align the arch using continuous arch, do the extraction of first premolar, retract the canine into extraction space, and after retracting canine, we will retract the incisors. But very carefully, we will add the intrusive component into the retraction of incisor, so that there is no appearance of curve of spee once we finish our retraction. For this, you can use non-sliding mechanics in the form of wool loop or any retraction arch having a intrusive component in it, which will make sure that as we retract the incisor, there is an intrusion of incisor, and we maintain the no curve of spee that was at the start of treatment. So the mechanics for this category, fourth category, we can use continuous mechanics. We do not need separate alignment of segments in these category of patients. We will do the extraction, retract the canine on continuous arch. After retracting the canines, we will retract the incisor using retraction arch or bull loop non-sliding mechanic, uh, having an intrusive component in it, so that there is no appearance of a deep bite after retraction of incisors. Our fifth category is category in which there is increased inclination, but there is also curve of spee is also present. That means there is a double uh, magnitude of the vertical problem, because there is curve of spee is also present and increased inclination. When we will retract the inclination, it will also lead to the increased depth of the bite. So the vertical problem is double in the magnitude. For these kind of patients, we will start the patient by extraction of first premolars. We will segmentally retract the canines using canine retractors, and we will align the incisor in a separate segment. Incisor are aligned in the separate segment, and the canines are first retracted segmentally using canine retractor, T-loop or any canine retractor. And once they are retracted into the extraction space, we will connect the right and left side of the arch by continuous arch, which will bypass the incisors, similar to the mechanics that we used in our first category. In preparation of this category is same as category 1 patients. We will align our right and left segments and bypass the anterior teeth. Anterior teeth incisors are aligned in a separate segment. Once we reach the heavier wire, 1725 or 1925, our arch is ready for retraction plus intrusion. But these patients, as the magnitude of the vertical problem is greater, there will be greater intrusion required, and minor component of the incisor retraction will be required. So on these patients, we recommend the use of 3-piece intrusion arch, which is the best arch when we require greater magnitude of intrusion and lesser magnitude of retractions. So we have prepared this patient having right and left side segments on continuous arch, bypassing the incisors, having archwire sleeve so that it doesn't irritate the patient. Incisor aligned in the separate arch, separate segment, and our first molars having double tube band with lingual arch placed. Our patient is now ready for placement of 3-piece intrusion arch. These kind of patients are ideal patients for 3-piece intrusion arch. Ultimate goal is to align our incisor in separate segment and right and left side in separate segments. Now this patient is ready for intrusion arch. Now we will have a practical demonstration of how to make an intrusion arch, on how to place and activate the intrusion arch. Now that
Is
our patient
ready for the intrusion arch. For making the intrusion arch, we will use this plier. This is bird beak plier. 1622 SS wire will be used. This is a model for demonstration. We will place the wire on the model, mark the wire distal to lateral incisor, then hold the wire at that mark that was marked on distal to lateral incisor. We will give the wire a bend of 90 degrees. This is a downward bend. Then we will hold the wire at 6 mm. We can place the mark at 6 mm measurement. Then place a 90-degree bend again on the wire. Then place the wire on the model We will place a mark mesial to the molar, 2-3 mm mesial to molar. We will hold the wire. On all bends, we will hold the wire along the round side of the bird beak plier. Give the wire a 90-degree bend in the upper direction. Now hold the wire at 3 mm or 4 mm mark. Give it a 90-degree bend. It will be in this form. Distal to lateral incisor, the wire goes down. Then at 6 mm or 6, 7, 8 mm, depending upon the depth of the vestibule of the patient, we will give it a 90-degree bend to bypass the 3, 4 and 5. Then mesial to the molar, we will again bring the wire upward and we will bend the wire again at 90-degree, 3 or 4 mm. Similarly, on the other side, we will place a mark on distal to lateral incisor, measuring on the cast. Hold the wire on that mark, place a downward bend of 90 degrees. Then at 6 to 7 mm, we will place a wire, again 90-degree bend. Then we will measure on the cast, place a mark mesial to the molar and hold the wire at that mark. Mesial to molar, we will bring it upward bend of 90 degrees. Then we will place a bend 3 to 4 mm. This is the wire intrusion arch. It is going down distal to lateral incisor, then bypassing the premolars and canine, then again mesial to molar. It is upward. It is passed through the accessory tube of the molar, right and left side, both side. And then now for the activation of intrusion arch, we will hold the wire at this point and give it a downward 25 degrees bend on both sides.
Both sides we will give a downward bend of 25 degrees. Now we will pass this wire into the molar's accessory tube. The wire will lie downward in the anterior section. We will bring the wire upward and tie it with ligature wire distal to lateral incisor on both sides. It is downward in the anterior section. We will bring the wire upward and tie it into the distal to lateral incisor. As we have already discussed, our anterior segment has a separate wire, anterior, central and lateral incisor. We will bring this wire upward and tie it to that wire at point contact distal to lateral incisor on both sides. In this way, it will be activated. It should not impinge on the patient. If it should not impinge on the patient's gum at any point. If it impinges, the wire should be adjusted such a way that wire at all points wire is 1 or 2 mm away from the gums. In order to make it more comfortable for the patient, this is the piece of archwire sleeve which was used in the initial segment to cover the wire when it was bypassing these incisors. We can pass this wire we can pass this wire into archwire sleeve wire You can see that we have slowly passed the archwire sleeve on the wire. This archwire sleeve will make the wire comfortable for the patient. There's archwire sleeve passed on the wire to make it comfortable. Similarly, we will pass a section of archwire sleeve on this side as well, so that with archwire sleeve, these segments are very comfortable for the patient. Now for making 3-piece intrusion arch, we will take a wire 1622 SS wire. We will mark distal to lateral incisor. We will mark a point on the wire distal to lateral incisor, giving it a downward 90-degree bend. Then we will hold the wire at 6-7 mm point, give it a 90-degree bend. Then we will make a loop at this point. We will make a loop. You can see there's a loop. Similarly, on the left side, we will place a mark distal to lateral incisor, hold the wire from that mark, give it a 90-degree bend downward. Then again at 6 to 8 mm, we will give it a distal bend of 90 degree. Then we will make a loop at the end of the wire. This way. This is the one interior piece of a 3-piece arch. We will place this wire in the interior incisor, ligate it in the brackets. Now we have right side. We have right side and left side. This is a one piece of the intrusion arch, 3-piece intrusion arch. Now we'll take a wire, place it in the main tube of the first molar, ligate it in second premolar, first premolar and canine, ligate it in second premolar, first premolar and canine. This is the second piece of 3-piece intrusion arch. We will bilaterally ligate the wire in right and left segments. So we have one segment that is ligated in canine, first premolar, second premolar and molars main tube. We have one interior segment which is ligated in the bracket of 4 incisors. It has hook in the downward direction, 6 mm down. This is hook for activation. One piece. Second piece is ligated in the molar 4, 5, 6, and now we'll make the third piece. Third piece we will make a loop. We have made a loop and we will make hook at the interior segment. This way. Distal to loop, we will give 25-degree downward bend for activation of the for activation of the 3-piece intrusion arch. This is the final piece of 3-piece intrusion arch. This we will place it in the accessory tube of first molar. It will lie downward. We will bring it up and place it in the loop that we have formed of anterior segments loop. This piece will lie downward. We will, because of the bend that we have given activation bend, we will bring it upward and place it in this hook. This way it will press the anterior segment in the downward direction and it will be activated for the intrusion force. This segment, like it activated in the accessory tube of the molar, it will lie downward. It will be brought upward and activated in the hook of the anterior segment. Now to give a retraction component to this mechanic, we will place a 3 or 4 unit power chain from the hook of first molar to this loop that we have formed of the anterior segment. By placing the power chain in this fashion, will give the overall mechanics a retractive component. So we have intrusion and retraction of the anterior segment with more intrusive component and less retractive component. So this is the 3-piece intrusion arch.